Today let's see the disease of retina. Applied anatomy. The innermost unit of the eyeball is a thin, delicate, transparent membrane. It is most highly developed tissue of the eye. It appears as purplish red due to visual purple of the rods underlying vascular choroid. Gross anatomy. Retina extends from optic disc to ora serrata with a surface area of about 266 mm square. Retina is thickest in peripapillary region and the thinnest at the ora serrata. Grossly, it can be divided into two distinct regions: posterior pole, peripheral retina, separated by so-called retinal equator. Retinal equator is an imaginary line which is considered to lie in with exit of four verticose vein. Vena verticose. Posterior pole refers to area of retina posterior to retinal equator. Posterior pole of retina includes two distinct areas: optic disc and macula lutea. Posterior pole of retina is best examined by slit lamp indirect biomicroscopy using +78D +90D lens by direct ophthalmoscopy. Optic disc. It is a pink colored, well defined vertically oval area with the average dimension of 1.76 mm horizontally and 1.8 mm vertically. It is placed 3.4 mm nasal to fovea. At the optic disc, all the retinal layers terminate except the nerve fibers, which pass through the lamina cribrosa to run into optic nerve. The optic disc thus represents the beginning of optic nerve. So it also refers to as optic nerve head. A depression seen in disc is called physiological cup. The central retinal artery and vein emerge through center of this cup because of absence of photoreceptor. The optic disc produces an absolute scotoma in the visual field as known as physiological blind spot. Macula lutea, it is called as yellow spot. It is comparatively deeper red than the surrounding fundus. It is situated at the posterior pole, temporal to optic disc. It is about 5.5 mm in diameter. Fovea central is the central depressed part of the macula. It is about 1.5 mm diameter and is most sensitive part of retina. Sensitive. With the lowest threshold for light and highest visual acuity because it contains only cones. In its center, it is a shining pit called foveola. Only cones. Which is situated about 2 disc diameters away from temporal margin of the disc and about 1 mm below the horizontal meridian. The tiny depression in the center of foveola is called umbo, tiny depression, which is seen as shining foveal reflex on fundus examination. An area about 0.8 mm in diameter, including foveola and some surrounding area, does not contain any retinal capillaries and is called foveal avascular zone. Surrounding fovea are the parafoveal and perifoveal areas. Peripheral retina refers to area bounded posterior by retinal equator and anterior by ora serrata. Peripheral retina is best examined with indirect ophthalmoscopy and by use of Goldman 3-mirror contact lens. Ora serrata is the serrated peripheral margin where retina ends. Here, the retina is firmly attached to both vitreous and choroid. The pars plana extend anteriorly from ora serrata. Microscopic structure. Retina contains 10 layers arranged in two distinct functional compounds: pigment epithelium and neurosensory retina, with a potential space between the two. Neurosensory retina consists of 3 types of cells: the air synapses and the air synapses. We'll see the retina, gross anatomy retina, parts of retina in horizontal section at the level of fovea, diagrammatic fundus view and fundus photography. Optic nerve, optic disc, fovea, choroid, retina, sclera. This one is ora serrata. And here optic disc, ora serrata, macula, parafoveal region, fovea centralis, foveola and fovea centralis, retinal vessels and etc. Pigment epithelium, it is the outermost layer of retina. It consists of single layer of cells containing pigment. It is firmly adherent to underlying basal lamina, Brooks membrane of choroid. Pigment epithelium provides metabolic support to neurosensory retina and also acts as an anti-reflective layer. Interphotoreceptor matrix is present in potential space between pigment epithelium, neurosensory retina, and constitutes a strong binding mechanism between two. Constituent molecules of IPM include interphotoreceptor retinal binding protein (IRBP), proteoglycan, glycosaminoglycans, sulfate, non-sulfate, chondroitin, and hyaluronic acid. Protein associated with rods and cones, intercellular adhesion molecules, hyaluronic acid receptors, and lysosomal tissue inhibitors of metalloproteinase (TAMP). Layers of rods and cones are end organs of vision and are also known as photoreceptors. Layers of rods and cones contain only outer segments of photoreceptor cell arranged in palisade manner. There are about 120 million rods and 6.5 million cones. Rods contain a photosensitive substance, visual purple rhodopsin, subserve peripheral vision and vision of low illumination, scotopic vision. Cones are contain photosensitive substance and are primarily for highly discriminant central vision and color vision. External limiting membrane, it is a fenestrated membrane through which past process of rods and cones. Outer nuclear layer, it consists of nuclei of rods and cones. Outer plexiform layer, it consists of connection of rods, spherules, cone pedicles with dendrites of bipolar cells and horizontal cells. Inner nuclear layer, it mainly consists of cell bodies of bipolar layers. It also contains cell bodies of horizontal amacrine Muller cells and capillaries of central artery of retina. The bipolar cell contains the first order neurons. And inner plexiform layer, it essentially consists of anisymmetry axons of bipolar cell and dendrites of ganglion cells and process of amacrine cells. Ganglion cell, it mainly contains the cell bodies of ganglion cells. There are two types of ganglion cells. Midget ganglion cells are present in the macular region, and dendrite of each cell such cell synapses with the axon of single bipolar cell. Polysynaptic ganglion cell lie predominantly in the peripheral retina. Each such cell may synapse with the 100 bipolar cells. Nerve fiber layer, stratum opticum, consists of axons of ganglion cells which pass through lamina corporosa to form optic nerve. For distribution and arrangement of retinal fibers, we'll see the diagram respectively on page 233. Internal limiting membrane is the innermost layer and separates the retina from vitreous. It is formed by union of terminal expanse of Muller's fibers and is essentially a basement membrane. Structure of fovea centralis, we'll see. And this is a microscopic structure of retina. This one is rod, this one is cone, optic nerve fibers, pigment epithelial layer of rods and cone, external limiting layer, cone nucleus, rod nucleus. Rod is for scotopic vision, cone is for color vision. Outer nuclear layer, outer plexiform layer, inner nuclear layer, amacrine cell, horizontal cell, bipolar cell, polysynaptic ganglion cell, inner plexiform layer, ganglion cell layer, nerve fiber layer, internal limiting layer. Structure of fovea centralis, we'll see in the diagram 12.3. There are no rods and cones are tightly packed. Other layers of retina are very thin. Its central part largely consists of cones and their nuclei covered by a thin internal limiting membrane. All other retinal layers are absent in this region. In the foveal region surrounding the foveola, the cone axons are arranged obliquely Henle straight to reach the margin of fovea. Choriocapillaries, pigment epithelium, elongated cones, outer nuclear layer, Henle layer, retinal capillaries, inner nuclear, inner plexiform layer, ganglion cell layer, nerve fiber layer, internal limiting membrane. Function divisions of retina. Functionally, retina can be divided into temporal retina and nasal retina by line drawn vertically through center of fovea. Fibers arising from temporal retina pass through optic nerve and optic tract of same side to terminate in the ipsilateral geniculate body, while the nerve fibers originate from nasal retina after passing through optic nerve cross in the optic chiasma and travel through contralateral optic tract to terminate in contralateral geniculate body. Neurons of geniculate body constitute the third order neurons in visual pathway. Blood supply. Outer four layers of retina. Pigment epithelium, layers of rods and cone, external limiting membrane, outer nuclear layer, avascular, get their nutrition from choroidal vascular system, found by contribution from anterior ciliary arteries, posterior ciliary arteries. Inner six layers of retina are vascular and get their supply from central retinal artery, which is a branch of ophthalmic artery. In some individual, ciliary retinal artery is present as congenital variation supplies in the macular region. In such cases, central vision is retained in the eventually of central retinal artery occlusion. Central retinal artery emerges from center of physiological cup of optic disc and divides into four branches, namely superior nasal, superior temporal, inferior temporal. These are end arteries. They do not anastomose each other. However, anastomose between retinal vessels and ciliary system of vessels, short posterior ciliary vessel, does not exist with vessels which enter the optic nerve head from arterial circle of Gin or hilar. Branches of this skull invade lamina cribrosa and also send branches to optic nerve head. Retinal vessels, these follow pattern of retinal arteries. The central retinal veins drain into cavernous sinus directly or through superior ophthalmic vein. Blood supply of optic nerve head we'll see in the future. Congenital and developmental anomalies. Anomalies of optic disc, anomalies of nerve fibers, anomalies of vascular elements, anomalies of retina purpura, congenital anomalies of macula, anomalies of optic disc, coloboma of optic disc. It results from failures in closure of embryonic fissure. It occurs in two forms. Coloboma. It is minor effect, is more common and manifest as inferior crescent, usually associated with hypermetropic or astigmatic refractory error. Fully developed coloboma typically presents inferior nasally as a very large with a white excavation which apparently looks as the optic disc. The actual optic disc seen as linear horizontal pinkish band confined to a smaller superior edge. Defective vision and superior visual field defect is usually associated. Drusen of the optic disc. Drusens are interpurpurally refractile bodies which usually lie deep beneath the surface of disc tissue in childhood and emerge out to be by early teens. Thus, in children, they present as pseudopapilloedema, and teens they can be recognized ophthalmoscopically by waxy pea-like irregular retractile bodies. Hypoplasia of optic disc. It may occur as an isolated anomaly or in association with other anomalies of central nervous system. The condition bilateral in 60% of cases and is associated with maternal alcohol use, diabetes, and intake of certain drugs in pregnancy. It forms a significant cause of blindness at birth in developing countries. Diagnosis of mild cases present little effect. You feel difficulty. In typical cases, the disc is small, surrounded by a yellowish and pigment ring referred to as double ring sign. Medullary nerve fibers. These are also known as opaque nerve fibers, represent myelination of nerve fibers of retina. Normally, medullation of optic nerve proceeds from brain downward to eyeball and stops at the level of lamina cribrosa. Occasionally, the process of myelination contributes after birth for an invariable distance in nerve fiber layer. An ophthalmoscopic examination, these appear as whitish patch with feathery margin, usually present adjoining this margin. The traversing retinal vessels are particularly concealed by opaque nerve fibers. Such a lesion characteristically exhibit large enlargement of blind spot on visual charting. Middle sheath disappear in demyelinating disorders and optic atrophy. Thus, no trace of this abnormality is left behind. Persistent hyaloid artery. The hyaloid artery is present Bigmaster papilla, referred to flake of glial tissue proceeding from optic disc. It is common as congenital anomaly of hyaloid system. Vascular loop or thread of obliterated vessel may be seen running forward into vitreous. It may be even reaching the back of lens. Mittendorf dot represent remnant of anterior end of hyaloid artery attached to posterior lens capsule. It is usually associated with posterior polar cataract. Inflammatory disorders of retina. Retinitis. Non-specific retinitis. It is caused by pyogenic organism. May be either acute or subacute. Acute purulent retinitis. It occurs as a metastatic infection in patients with pyemia. The infection usually results the surrounding structures and soon converts into metastatic endophthalmitis or even panophthalmitis. Subacute retinitis of Roth. It typically occurs in patients suffering from subacute vital endocarditis. It is characterized by multiple superficial retinal hemorrhage involving posterior part of fundus. Most of the hemorrhages have a white spot in the center, Roth spot. Vision may be blurred due to involvement of macular region or due to associated papillitis. Specific retinitis. It may be bacterial or viral cytomegalic inclusion, herpes, mycotic rickettsial, cytomegalovirus, retinitis, zoster retinitis, progressive outer retinal necrosis caused by an aggressive variant of varicella zoster variant, acute retinal necrosis ARN caused by herpes simplex virus 2 in patient under age 15 years and by varicella zoster virus and herpes simplex virus 1 have become more conspicuous in patients with AIDS. Retinal vasculitis, inflammation of retinal vessel wall may be primary Ehlers disease or secondary to Ehlers disease. It's an idiopathic inflammation of peripheral retinal vessels. It is characterized by recurrent vitreous hemorrhage. It also refers as primary vitreous hemorrhage. The disease is rare in Caucasian but important visual morbidity in young Asian males. Etiology, not known etiology. Considered hypersensitivity reactions to tubercular proteins. Clinical feature: it is a bilateral disease typically affecting young adult males. The common presenting symptoms are sudden appearance of floaters in front of eye, sudden painless loss of vision due to vitreous hemorrhage. The hemorrhage clears up but recurrences are very common. Clinical course: Ehlers disease described stage of active inflammation, stage of ischemia, stage of retinal neovascularization, stage of sequelae or advancement of disease. Fundus photography showing typical cytomegalovirus retinitis in patient with AIDS. Note: white necrotic retinal associated with retinal hemorrhages. White necrotic retina. Fundus photograph of patient with Ehlers disease, stage of inflammation. Note: venous congestion, perivascular exudates and sheets of hemorrhage present near the fetal veins. Venous congestion and perivascular exudates. Stage of active inflammation. The affected peripheral veins are congestion, perivascular exudates, seething are seen along the surface. Superficial hemorrhages are ranging from flame-shaped to sheaths of hemorrhage may be present near the affected veins. Stage of ischemia or vascular occlusion is characterized by obliteration of involved vessels and development of areas of capillary non-perfusion in the periphery as evidence on fundus fluorescent angiography. Stage of retinal neovascularization marked by development of abnormal fragile vessels, junctions of perfused or non-perfused retina. Bleeding from this vessel lead to recurrent vitreous hemorrhage. Stage of sequelae or advanced stage of disease is characterized by development of complications such as proliferative Artery retinopathy, fractional retinal detachment, rubeosis iris, neovascular glaucoma. Treatment of Ehlers disease comprise medical treatment. Course of oral corticosteroid for extended periods is mainstay of treatment. During stage of active inflammation, as a course of anti-tubercular therapy, laser photocoagulation, retina either PRP or feeder vessel photocoagulation is indicated. Vitreoretinal surgery is required for non-resolving cases. Vascular disorders of retina, retinal artery occlusions, retinal artery occlusion. Occlusive disorders of retinal vessels are more common in patients suffering from hypertension and other cardiovascular disorders. Common cause of retinal artery occlusion are emboli from carotid artery and those of cardiac origin are most common. Three types of emboli: cholesterol emboli, calcium emboli, platelet fibrin emboli. These are refractile and orange and seen at retinal vessel. These arise from atheromas in carotid artery. Calcium emboli, white in color, arise from cardiac vessels. Platelet fibrin emboli are white, dull white in color, arise from atheromas in carotid artery. They may cause retinal ischemic attacks. TIA, atherosclerosis lateral thrombosis at level of lamina cribrosa is another common cause of CRAO. Retinal arthritis with obliteration associated with giant cell arthritis and periarthritis associated with polyarthritis nodosa, SLE, Wegener, scleroderma, other causes of CRAA. Angiosperm, rare cause of retinal artery occlusion. It is commonly associated with amaurosis. Raised intraocular pressure occasionally associated with obstruction of retinal arteries, for example due to tight encircle of retinal detachment surgery. Thrombophilic disorders such as inherited defects of anticoagulant may occasionally be associated with CRAO in young adults. Other rare causes are retinal migraine, sickling, hemoglobinopathies, hypercoagulation disorders such as oral contraceptive, polycythemia, etc. Clinical features: clinical retinal artery occlusion may present as central retinary artery occlusion or branch artery occlusion, cilio-retinal artery occlusion. It is more common in males than females. It is usually unilateral but central retinal artery occlusion. It occurs due to obstruction at the level of lamina cribrosa. Symptoms: patient complaint of sudden painless loss of vision occurring over seconds. Patient may give history of transient visual loss, more figures in the past. Signs of CROA are as below. Visual acuity is markedly reduced, 3/60, less than 3/60 in 90% cases, except in few cases with cilio-retinal arteries supplying the macula. Direct pupillary reflex is absent and relative afferent pupillary RAPD is positive. Fundus examination: marked narrowing retinal vessels and mild narrowing retinal veins. Retinal arteries, marked narrowing; veins, retinal mild narrowing. Retina becomes milky white due to ischemic edema in eyes with sealed retinal artery. Part of macula remains normal in color. Fundus photo showing marked retinal pallor in acute central retinal artery occlusion, with sparing of territory supplied by ciliary retinal artery and cherry red spot in the absence of ciliary retinal artery. Cherry red spot is seen in center of macula due to vascular choroid shining through thin retina in fovea region and in contrast to surrounding pale retina. Cattle tracking: segmentation of blood column is seen in the retinal veins. Atropic changes in most cases. Retinal edema resolves over a period of 4 to 6 weeks, and atropic changes in the form of grossly attenuated thread-like arteries, atropic appearing retina, and consecutive optic atrophy occurring in long-standing cases. Fundus fluorescent angiography shows delay in arterial filling and masking of choroidal vascularization due to retinal edema. Branch retinal artery occlusion: it usually occurs following lodgement of embolus at bifurcation. Retina distal to occlusion becomes edematous with narrow arteries. Temporal branch of retinal artery occlusion. Note retinal pallor in superior-temporal area and whitish embolia on optic disc and in superior temporal branch of retinal artery. Management: aggressive treatment of acute episodes of CRA. Manage immediate lowering of intraocular pressure, may aid in arterial perfusion and also help in dislodging embolus. Intermittent ocular massage, intravenous mannitol. Paracentesis of anterior chamber has been recommended for purpose. Intravenous acetazolamide 500 mg should be given immediately. Vasodilators and inhalation of mixture of 5% carbon dioxide, 95% oxygen may help by relieving element of angiosperm. Fibrinolytic therapy may be helpful in some cases. Intravenous steroids are indicated in patients with giant cell arteritis. Laser photodistribution of embolus has been reported in selected cases to dislodge the embolus. Workup for associated systemic conditions should be carried out immediately after emergency management of acute episodes. Corrective measures instituted. Complication: in some cases, neovascular granuloma with a incidence varying 2 to 6% may occur as a delayed complication of central retinal artery occlusion. Retinal vein occlusion: etiology: pressure of the vein in atherosclerotic retinal artery, where two share a common adventitia, so just behind the lamina corpuscle at arteriovenous crossing. Secondarily induced thrombosis in lumina vein. Hypertension, diabetes mellitus are common predisposing factors. Hyperviscosity of blood, as in polycythemia, hyperlipidemia, macroglobulinemia, leukemia, multiple myeloma, etc. Peripheral retina, which can be central or peripheral sarcoidosis, syphilis, SLE, etc. Raised intraocular pressure. Central retinal vein occlusion more common in patients with primary open angle glaucoma. Local cause are orbital cellulitis, orbital tumors, facial erysipelas, cavernous sinus thrombosis, etc. Classification: central retinal vein occlusion. It may be non-ischemic CRVO, venous stasis retinopathy, or ischemic CRVO, hemorrhagic retinopathy. Branch retinal vein occlusion, BRVO. CRVO, central retinal vein occlusion. Central retinal vein occlusion non-ischemic, central retinal vein occlusion ischemic. It is the most common clinical variety. It is characterized by mild to moderate visual loss and no RAPD. Early case on fundus examination show mild venous congestion, tortuosity, so few superficial flame-shaped hemorrhages, and more in the peripheral than posterior retina. Mild papillary edema, mild or no macular edema. In late stages, there appears sheathing around the main veins and a few ciliary-retinal collaterals around the disc. Retinal hemorrhages are partly absorbed. Macula may show chronic cystoid edema in moderate cases, or may be normal in mild cases. About 15% cases of non-ischemic CRVO are converted to ischemic CR in 4 months and about 30% in 3 years. Ischemic CRVO hemorrhage retinopathy refers to acute complete occlusion of central retinal vein. It is characterized by marked sudden visual loss and RAPD. Early cases on fundus examination. 12.10 central retinal vein occlusion, massive engorgement, congestion, tortuosity of retinal veins, massive retinal hemorrhage. Numerous cotton wool spots, usually more than 6 to 10%. 6 to 10. Discs show edema, hyperemia. Macular retina, macular area is full of hemorrhages and is severely edematous. Breakthrough vitreous hemorrhage may be seen in some cases. In late stage, marked seething around veins, collateral is seen around the disc. Neovascularization may be seen at the disc or in periphery. Macula shows marked pigmentary changes and chronic cystoid edema. Pathognomic features for ischemic, differentiating it from non-ischemic CRVO or presence of relative afferent pupillary defect RAPD, Marcus Gunn people. Visual field defects, reduced amplitude of B wave of electroretinogram. Complication: rubiosis, iridis, and neovascular glaucoma occurs in 20% of cases within 3 months. A few cases develop vitreous hemorrhage and proliferated retinopathy. Branch retinal vein occlusion (BRVO) (BRO). It may occur more common than central retinal vein occlusion. It may occur as hemispheric occlusion due to occlusion of main branched disc. Quadrant occlusion due to occlusion at the level of AV crossing. Small branch occlusion either as macular branch occlusion or peripheral branch occlusion. Features of BRVO: retinal edema, hemorrhages are limited to superior temporal branch of retinal vein occlusion (BRVO). Vision is affected only when macular area is involved. Secondary glaucoma occurs rarely in these cases. Chronic macular edema neovascularization may occur as complication of BRVO in about 1/3 cases. Management of retinal vein occlusion. Clinical evaluation and inclusions. Ocular examination and investigation. Ocular examination should include visual acuity at presentation at every follow-up and is a useful guide for intervention required. IOP should be recorded. Associated POAG should be ruled out. Undilated slit lamp examination to detect neovascularization of iris. Gonioscopy to rule out neovascularization of angle. Fundus examination with direct and indirect ophthalmoscopy and with 90D slit lamp examination. Ocular investigation should include Goldman perimetry. ERG evaluation is very important in differentiating between ischemia and non-ischemia CRVO. Fundus fluorescein angiography should be carried out to assess state of retinal perfusion after resolution of retinal hemorrhage. Usually areas of capillary non-perfusion of more than 10 disc area are seen in ischemic CRVO. Optical coherence tomography is particularly useful for evaluation of macular edema, subretinal fluid accumulation, development of epiretinal membrane. Systemic examination with investigation. Systemic examination which need to be looked for are hypertension, diabetes mellitus, heart disease, dyslipidemia, hypercoagulability condition, homocystinuria, etc. Different diagnosis. Diabetic retinopathy is generally bilateral. CRVO is usually unilateral. Ocular ischemic syndrome is due to carotid occlusive disease has only dilated veins without tortuosity. In CRVO, tortuosity is also seen. Retinal hemorrhages are typically seen in mild periphery. Treatment of systemic and ocular such as hypertension, diabetics, hyperlipidemias, hyperhomocystinemia, POAG, and other condition is important in all cases. Smoking should be avoided. Observation and monitoring should be observed and as condition, especially non-ischemic, and more than 50% of cases CRV resolved with almost normal vision. Ocular therapy as described below is required by patient presenting with marked visual loss, usually ischemic CRV, and those with progressive visual loss on observation. Medical therapy presently in vogue is intravitreal anti-VEGFs, example 1.25 mg bevacizumab or 0.3 mg ranibizumab are useful for associated CME and neovascularization. Intravitreal triamcinolone may be given for associated CME. Laser therapy, grid laser is not recommended for macular edema and CRVO. However, persistent CME in BRVO may be treated with grid laser. Pan-retinal photocoagulation is generally not recommended as prophylaxis even in cases with marked ischemia, except in patients not likely to comply with regular follow-up. PRP should be performed without delay in CRVO when neovascularization develops anywhere, that is in angle, iris, retina. PRP involves application of 1000 to 1500 to 3000 pounds spaced one bun with the apart using frequency doubling YAG laser or argon green laser. Scatter laser photocoagulation is recommended for neovascularization elsewhere in patients with BRVO. Surgical therapy may be required in form of pars plana vitrectomy for treating the following complications associated with venous occlusion: persistent vitreous hemorrhage, tractional retinal detachment, epiretinal membrane, intractable neovascular glaucoma. Note: PPV may be combined with endolaser PRP when required. Pars plana placement of glaucoma drain device may also be required in patients with NVG. Radical optic neurotomy once proposed to be transvitreal incision of scleral ring to surgically decompose CIV at level of scleral outlet has not provided useful. Hypertensive retinopathy. Hypertensive retinopathy refers to fundus change occurring in patients suffering from systemic hypertension. Although the term hypertensive retinopathy implies only retinal changes, but in fact, clinical presentation includes changes of hypertensive retinopathy, choroidopathy, optic neuropathy. Pathogenesis. 3 factors which play a role in pathogenesis of hypertensive retinopathy are vasoconstriction, arteriosclerosis, increased vascular permeability. Vasoconstriction. Arterial narrowing is the primary response to raised blood pressure and is related to severity of hypertension. Vasoconstriction of retinal arteries occur in pure form in young adults but is affected by pre-existing involution sclerosis in older patients. Vasoconstriction of choroidal vessels occur in causes choroidal or PE ischemia, which manifests as hypertensive choroidopathy. Vasoconstriction of peripapillary choroid leads to optic nerve head ischemia, manifesting as hypertensive optic neuropathy. Arterioscleral changes, which manifest as changes in arterial reflex AV nipping, resulting thickening of vessel wall and or reflection of duration of hypertension. Increased vascular permeability results from hypoxia and response for hemorrhages exudates. Focal retinal edema, macular edema, focal intraretinal periarterial transudates. Clinical types: chronic hypertensive retinopathy, malignant retinopathy. Chronic hypertensive retinopathy patients are usually asymptomatic. Clinical situations in which chronic hypertensive retinopathy include hypertension with involutionary sclerosis, chronic hypertension with compensatory arterial sclerosis. Hypertension with involutionary sclerosis occurs in elderly patients in presence of involutionary sclerosis of fundus changes comprising augmented arteriosclerotic retinopathy. The second condition, this condition is seen in young patients with prolonged benign hypertension, usually associated with benign nephrosclerosis. The young arterial response by proliferator and fiber changes in media, compensatory arterial sclerosis. Advanced fundus changes in these patients have been described as albuminuric or renal retinopathy. Fundus changes of chronic hypertensive retinopathy can be summarized: generalized arterial narrowing, first point, or attenuation depending upon severity of hypertension, may be mild or marked. Consists of vasoconstricting sclerotic phase. Vasoconstrictive phase occurs due to diffuse vasospasm, which manifests when significant elevation of BP has persisted for an appreciable period and is characterized by an increase in retinal arterial tone. Sclerotic phase occurs due to intimal thickening, hypoplasia of tunica media, hyaline degeneration. Second is focal arterial narrowing. Is seen in areas of local vascularization of disc within half disc diameter. Arteriovenous nicking is the hallmark of hypertensive retinopathy. Occurs when arterial crosses and compresses the vein as the vessels share a common adventitious sheath, also known as AV crossing. Changes: Salu sign, bonnet sign, gun sign, tapering a vein on either side of crossings, bonnet, banking of vein distal to arteriovenous crossing, deflection of veins at arteriovenous crossing. Arterial reflex changes: the normal right reflex of retinal vasculature is formed by refraction from interface between blood column and vessel wall. Bright and thin linear blood reflex seen normally over the surface of arterial and engaged and predominantly because of blood column in arterial. More diffuse and less bright reflex seen due to thickening of vessel wall and represent changes in of grade 2, grade 1, grade 2 hypertensive retinopathy. Copper wiring, reddish brown reflex of arterial occur due to progressive sclerosis hyalinization and is sign of grade 3 retinopathy. Silver writing, grade 4 opaque white reflex of arterial occurs ultimately due to continuous sclerosis. Superficial retinal hemorrhage, flame shaped, occur at posterior pole due to distribution of capillaries in retinal nerve fiber layer. These hemorrhages disappear in 3 to 5 weeks. Hard exudates, lipid deposits in outer plexular layer retina. They appear as yellowish waxy spot. We arrange macular furrow and macular star. Temporary and may disappear in 3 to 6 weeks. Cotton wool spots fluffy white lesions and represent the areas of infarct in the nerve fiber layer. These occur due to ischemia caused by capillary obliteration in several hypertensive retinopathy. Due to their cotton wool feathery appearance, they are known as soft misnomer. It is a misnomer. Malignant hypertensive retinopathy. The fundus picture is given in 12.2, 12.12d. It is caused by changes of acute hypertensive retinopathy, choroidopathy, and optic neuropathy. It is not a separate variety of hypertension, but is expression of its rapid progression to a serious degree of patients. Acute hypertension retinopathy includes marked arterial narrowing due to spasm of arterial wall and response to sudden rise in blood pressure. Superficial retinal hemorrhages, flame-shaped, arranged in clusters, appear in posterior pole. Focal intraretinal periarterial transexudates, FIBTs, are small white focal oval lesions occurring due to deposition of macromolecules along the major arterioles. These result due to breakdown of blood retinal barrier following dilation of terminal arteries as a result of sudden rise in blood pressure in malignant hypertension. Cotton wool spots are also more marked in malignant hypertensive retinopathy. Microaneurysms and vessel collateral may develop as a result of capillary obliteration. Acute hypertensive choroidopathy change include acute focal retinal pigment epitheliopathy characterized by focal white spots occur due to acute ischemic change in choriocapillaries. Elschnick spots are small black spots surrounded by yellow hollows. These are formed due to clumping and atrophy of infarct pigment epithelium. Described below, Seychelles streaks are formed due to linear configuration of pigment along the choroidal arterioles. These are formed due to fibrinoid necrosis associated with malignant hypertension. Serous neurosensory retinal detachment, which preferentially affect the macular area, may occur due to accumulation of fluid beneath the retina following breakdown of outer retinal barrier owing to ischemic change to retinal pigment epithelium. It may also manifest as exudative bullous retinal detachment with shifting subretinal fluid. Acute hypertensive optic neuropathy changes include disc edema and hemorrhage on disc and peripapillary retina, which occur due to vasoconstriction of peripapillary choroid vessels supplying the optic nerve head. The ischemia of optic nerve head leads to stasis of axoplasmic flow. Thus, the lesion is form of anterior ischemic optic neuropathy. Disc pallor of variable degree may occur late in the course of disease. Staging of hypertensive retinopathy. Several classification has been described. No classification is clinically useful. A few popular classifications are given below. Keith and Wagner classification grade 1, 12.2a. Mild generalized arterial attenuation, particularly of small branches with broadening of arterial light reflex and vein concealment. Mild generalized arterial attenuation, particularly of small branches. Grade 2, marked generalized narrowing and focal attenuation of arterial associated with deflection of veins at arteriovenous crossings. Solus signs. Grade 3, grade 2 changes plus copper wiring of arterioles, banking of veins distal to arteriovenous crossings. Sorry, this one grade 1 and appearing tapering of veins on either side of crossings. Gun sign. Right angle deflection of veins, hollow sign. Flame shaped hemorrhage, cotton wool spots and hard exudate are also present. 12.12c. All changes plus silver wiring of arterial and papillary edema. Key classification. Stage 0, no visible retinal abnormality. Stage 1, diffuse arterial narrowing, no focal constriction. Stage 2, more pronounced arterial narrowing with focal constriction. Stage 3, focal and diffuse narrowing with retinal hemorrhages. Stage 4, retinal edema, hard exudates, optic disc edema, etc. Grade of light reflex changes stemming from arterial sclerosis. Grade 0, normal. Grade 1, broadening of light reflex with minimal arteriolo-venous compression. Grade 2, light reflex changes with arterio-venous crossing changes more prominent. Grade 3, copper wire appearance. Grade 4, silver wire appearance and severe arteriovenous crossing. Wong McIntosh classification. Mild retinopathy characterized by one or more of following signs: generalized arterial narrowing, focal arterial narrowing, AV nicking, arterial wall reflex broadening. There is weak association with stroke, coronary heart disease, cardiovascular mortality. Moderate retinopathy consists of mild retinopathy with one or more of following signs: retinal hemorrhage, blot and dot or flame shaped microaneurysm, cotton wool spots, hard exudate. There is strong association with stroke. congestive cardiac failure, renal dysfunction, cardiovascular mortality. Accelerated retinopathy consists of moderate retinopathy signs plus optic disc swelling, may be associated with visual loss. Associated with moderate and renal failure. Management: mild hypertensive retinopathy requires blood pressure control only. Moderate hypertensive retinopathy patients, in addition to blood pressure control, benefit from further assessment of vascular risk factors. If indicated, risk reduction therapy should be given. Accelerated hypertensive retinopathy characterized by bilateral disc swelling, which may occur in conjunctiva with severe hypertension, needing urgent anti-hypertension management. In such instances, physicians should aim for small stepwise control of blood pressure over a few hours and avoid sudden reduction. Retinopathy in pregnancy induced hypertension is known as toxemia of pregnancy. Is a disease unknown etiology caused by raised blood pressure. Retinal changes are liable to occur when blood pressure rises above 160 by 100 or marked when blood pressure rises above 200 by 130. Early changes consist of narrowing of nasal arteries, following by generalized narrowing. Severe persistent spasm of vessels cause retinal hypoxia, cotton wool spots. Further progression of retinopathy occurs if pregnancy is allowed to continue. Retinal edema and exudation is usually marked and may associate with macular star or macular detachment. Rarely it may complicate by bilateral exudative retinal detachment. Prognosis for retinal detachment is good as it occurs spontaneously within a few days of termination of pregnancy. Management: changes of retinopathy are reversible and disappear after delivery unless organic vascular disease is established. In pre-organic stage, when patient responds well to conservative treatment, the pregnancy may justifiable be continued under close observation. Advent of hypoxic retinopathy, however, should be considered as indication of termination of pregnancy. Otherwise, permanent visual loss or even loss of life, both mother and fetus, may occur. Diabetic retinopathy: retinal changes seen in patients with diabetic mellitus. With the increase in life expectancy of diabetes, the incidence of diabetic retinopathy has increased. Diabetic retinopathy is leading cause of blindness. Etiopathogens, risk factors. Duration of diabetes is most important determining factor. After 10 years, 20% type 1, 25% type 2. After 20 years, 90% type 1, 60% type 2. After 30 years, 95% both type 1 and type 2 diabetes develop retinopathy. Age of onset of diabetes also acts as factor. Risk of retinopathy in child with onset of diabetes at age 2 is negligible for first 10 years. After onset of diabetes, age of onset is not a risk factor. 6 more in females than in males. Poor metabolic control less important than duration, but is nevertheless relevant to development. Hereditary recessive trait without sex linkage. Pregnancy may accelerate the changes of diabetic retinopathy. Hypertension, when associated with, may also accentuate the changes of diabetic retinopathy. Other risk factors include smoking, obesity, anemia, hyperlipidemia, etc. Pathogens: hyperglycemia, microangiopathy affecting retinal precapillaries arteries, capillaries, venules produced by hyperglycemia in the basic pathology in diabetic retinopathy. Mechanism by which hyperglycemia produces microangiopathy includes cellular damage. Hyperglycemia produces damage to cells of retina, endothelial cells, loss of pericytes, thickening of basement membrane of capillaries followed by effects, orbital accumulation in cells due to aldose reductase mediated glycolysis. Advanced glycation in products accumulate in cells due to non-enzymatic binding of several covalent protein, activation of several protein kinase isoform, excessive oxidation stress to cells due to excessive of free radical. Hematological and biochemical changes induced by hyperglycemia which play a role in development of microangiopathy include platelet adhesiveness increase, blood viscosity increase, red blood cell deformation, rodi formation, serum lipids altered abnormal, leukostasis increased due to increased intracameral adhesion, ICAM level expression, fibrinolysis increase. Effect of microangiopathy producing DR include breakdown of retinal blood barriers, leads to retinal edema, hemorrhage, weakened capillary wall, produce microaneurysm, hemorrhages, microvascular occlusion, produce ischemia and its effect. Artery venous shunts, intraretinal microvascular abnormalities, IRMAS, neovascularization of retina, pro-angiogenic factors such as VEGF, platelet derived growth factor, HGF, hepatocyte, which are released as a result of ischemia produced by microvascular occlusion. Release of angiogenic factors is also mediated by hyperglycemia induced oxidative stress, activation of protein C kinase, cytokine, deletion of anti-angiogenic factors such as pentostatin, angiostatin, pigment epithelial derived factor, PEDF, thrombospondin 1, platelet factor 4 also play a role in causing neovascularization. Speculator pathogens of DR based on above described changes in summarization flowchart 12.3. We'll see. Classification of diabetic retinopathy. Non-proliferative diabetic retinopathy, mild NPDR, moderate NPDR, severe and very severe. Flowchart depicting pathogens of diabetic retinopathy. Vascular and hematology is changing diabetic mellitus, thickening of capillary basement membrane, capillary endothelial cell damage, RBC deformation, Rouleau formation, increased thickness of platelets, increased plasma viscosity, loss of capillary pericytes, then microvascular occlusion, retinal ischemia, capillary leakage, microaneurysm, hemorrhage, retinal edema, heart exudates, arteriovenous, intraretinal microvascular abnormalities, neovascularization, proliferative diabetic retinopathy, diabetic maculopathy, advanced diabetic eye disease, non-proliferative diabetic retinopathy, ophthalmoscopic non-proliferative diabetic retinopathy, microaneurysm was seen in macular area, the earliest detection elsewhere in relation to area of capillary non-perfusion. These are formed due to focal dilation of capillary wall following loss of pericytes. These appear as red dots, leak fluid, protein, etc. Retinal hemorrhage, both deep dot and blot hemorrhage, which are common, flame-shaped, superficial, occur from capillary leakage. Retinal edema characterized by retinal thickening, scarpy capillary leakage. Hard exudates, yellowish white waxy looking patches are arranged in clumps or in circinate pattern. These are commonly seen in macular area. These occur due to chronic localized edema composed of liquid lipoprotein, lipid filled macules. Macrophageal cotton wool spots are small, whitish, fluffy superficial lesion. These represent the areas of nerve fiber influx. Venous abnormalities, bleeding, looping, dilation occur adjacent to area of capillary non-perfusion. Intrarenal microvascular abnormalities, IRMA, seen as fine irregular red lines connecting arterioles with venules, representing arterial shunts. Dark blood hemorrhages, representing hemorrhagic retinal influx. ETDR study classification: mild NPDR, at least one microaneurysm is present. Moderate NPDR, microaneurysms, intraretinal hemorrhage in 2 or 3 quadrants. Early mild IRMA, hard soft exudates may or may not present. Severe NPDR, any one of following 4-2-1 rule: 4 quadrants of microaneurysm, extensive intraretinal hemorrhage, 2 quadrant of venous bleeding, 1 quadrant of IRMA change. Very severe NPDR, any 2 of the following 4-1 rule: 4 quadrants of microaneurysm, extensive intraretinal hemorrhage, 2 quadrants of venous bleeding, 1 quadrant of IRMA changes. Risk factors for progression to PDR observed in ETDRs include presence of IRMA, multiple increasing intraretinal hemorrhage, venous bleeding loops, widespread capillary non-perfusion areas. Proliferative diabetic retinopathy develops more than 50% of cases after about 25 years of onset of disease. Therefore, it is more common in patients with juvenile onset diabetes. Occurrence of neovascular over changes of very severe non-proliferative diabetic retinopathy is hallmark of PDR. It is characterized by proliferation of new cells from capillaries in the form of neovascularization in optic disc or elsewhere in the fundus, usually along the course of major temporal retinal vessels. Diabetic retinopathy, mild NPDR, moderate NPDR, severe NPDR. Mild non-proliferative diabetic retinopathy, moderate, severe, very severe. Early proliferative diabetic retinopathy, high risk PDR, focal exudative diabetic maculopathy, later on results in formation of fibrovascular retinal membrane formed due to condensation of connective tissue along the new vessel. Vitreous detachment and vitreous hemorrhage may occur in the stage. Types on the basis of high risk characteristic described in diabetic retinopathy studies group. The PDR can be further classified as early NVD, NVE, PDR without HRS, PDR with HRS. PDR as follows: NVD 1/4 to 1/3 of disc area with or without vitreous hemorrhage or periretinal hemorrhage. NVD less than 1/4 disc area with VH or PH. NV greater than 1/2. Diabetic maculopathy, changes in macular region need to be special mentioned. These changes may be associated with NPDR or PDR. Diabetic macular edema occurs due to increased permeability of retinal vessels. Clinical significant macular edema during AD treatment, it is diagnosed as if one of the following 3 criteria are present in slit lamp examination with 90D lens: thickening of retina at or within 500 micron of central of fovea, hard exudates at or within 500 micron of central of fovea, associated with adjacent retinal thickening and development of zone of retinal thickening 1 disc diameter or larger in size. Clinical angiography classification of diabetic maculopathy. Focal exudative maculopathy. It is characterized by microaneurysms, hemorrhages, well-circumscribed macular edema, and hard exudates, which are usually seen arranged in circinate pattern. Fluorescein angiography reveals focal leakage with adequate macular perfusion. Diffuse exudative maculopathy. It is characterized by diffuse retinal edema and thickening throughout posterior pole with relatively few hard exudates. Fluorescein angiography reveals diffuse leakage at posterior pole. Ischemic maculopathy. It occurs due to microvascular blockage. Clinically, it is characterized by marked visual loss with microaneurysm, hemorrhage, mild or no macular edema, few hard exudates. Fluorescein angiography shows areas of non-perfusion, in which early cases are informed enlargement of foveal avascular zone. Later on, areas of capillary dropouts are seen, and in advanced case, precapillary arteries are blocked. OCT classification: non-tractional DME. It may be followed types: spongy thickness of macula, cystoid macular edema, neurosensory detachment with or without above. Tractional DME: vitreofoveal traction, taut thickened posterior highlight membrane. Advanced diabetic eye disease, persistent vitreous hemorrhage, tractional retinal detachment, neovascular glaucoma. Management: screening of diabetic retinopathy to prevent visual loss occurring from diabetic retinopathy. Following periodic examination, recommended following examination. First examination 5 years after diagnosis of type 1 DM. At time of diagnosis type 2 DM. Every year till there is no retinal diabetic retinopathy, there is mild NPDR. Every 6 months moderate NPDR. Every 3 months in severe NPDR. Every 2 months in PDR with no high risk characteristics. Investigation in case of DR: urine examination, blood sugar, 24-hour urine protein, renal function test, lipid profile, hemogram, glycosidic hemoglobin, HbA1c, fundus fluorescein angiography, optical coherence tomography. Treatment of diabetic retinopathy. Treatment models for diabetic retinopathy include metabolic control of DM associated with risk factors, intravitreal anti-VEGF drugs, intravitreal steroids, laser therapy, splenectomy, etc. Metabolic control of diabetes mellitus associated risk factors. It is first and foremost important to establish DM metabolically. Not only blood glucose levels to be normal, but other biochemical parameters should be normal. Control of glycemia, control of dyslipidemia. Renal function test, blood urine protein, 24-hour urinary protein 200 mg. Control of associated anemia, control of associated hypertension. Lifestyle changes: smoking, alcohol, quitting alcohol, intravitreal anti-VEGF drugs, bevacizumab antibody, MABs antibody, ranibizumab intravitreally in 0.1 ml vehicle lead to improvement in vision in greater than 40% of cases. These drugs should be preferred oral laser therapy in patients with focal CME, diffuse DME, diabetic CME, DME with neurosensory detachment. Anti-VEGF are also recommended before pan-retinal photocoagulation with PDR and diffuse DME. Note: intravitreal steroids given. Triamcinolone is another drug which is being tried. It restores inner retinal barrier and has some anti-VEGF effects also. Laser therapy, ETDR are recommended. Focal laser for focal DME, grid laser for diffuse DME. Laser helps possibly stimulating RPE pump mechanism by inhibiting VEGF release. Till recent, laser therapy which can stabilize the vision as mainstay of treatment. However, with the introduction of anti-VEGF which also improve vision, the role of laser therapy has become limited. Laser therapy is performed using double frequency arc laser 532. Protocols for laser therapy are macular photocoagulation, grid photocoagulation. It's of today focal photocoagulation, grid photocoagulation. Treatment of choice for focal DME not involving central of fovea. It is grid is more the treatment of no more treatment choice for diffuse DME. Then in PRP, inferior quadrant of retina is first coagulated. PRP produces destruction of hypoxic retina. Indication for PIP or PDR with HRC, neovascularization of iris, severe NPDR associated, one-eyed patient, pregnancy, etc. Surgical treatment: traction DME with NPDR. Treatment of choice in splenectomy with removal of posterior highlight. Advanced PDR with dense vitreous hemorrhage, PPV along with removal of opaque vitreous. Advanced PDR with extensive fibroscopy epiretinal membrane should be treated with PPV. Protocols of laser application, diabetic retinopathy, focal treatment, grid treatment, pan-retinal photocoagulation. Advanced PDR with tractional retinal detachment. Retinopathy in blood vessels, sickle cell retinopathy, retinal hypertension which results from blockage of small vessels. Clinical feature: stage of peripheral arterial occlusion, peripheral arteriovenous anastomosis, neovascularization, vitreous hemorrhage, vitreoretinal traction bands, traction retinal detachment. Treatment: pan-retinal photocoagulation, PRP, large spinal vitrectomy required for vitreoretinal traction band. It should be followed by repair of retinal detachment when present. Anemic retinopathy: retinal changes are liable to occur when hemoglobin levels falls by 50% or constantly present when it is below 35. Duration: type of anemia do not influence occurrence of retinopathy. Pathogen involve factors like anoxia, venous stasis, angiosperm, increased capillary permeability, thrombocytopenia. Characteristic features of anemic retinopathy are as follows: fundus background becomes pale, retinal arteries are also pale, retinal vessel veins are tortuous and dilated, retinal hemorrhage, superficial flame-shaped pre-retinal may be seen in posterior half of fundus. Root spots: hemorrhage with white center and platelet fibrin emboli constitute the white center. Cardinal spots are seen. Management: treatment of anemia, intervention large subhyaloid hemorrhage, York posterior hysterectomy. Characteristic feature: leukemic retinopathy include fundus background pale, retinal vessels are tortuous and dilated, retinal arteries become pale and narrow, perivascular leukemic infiltration, rough spots, subhyaloid hemorrhage. Retinopathy of prematurity is bilateral proliferative retinopathy occurring in premature infants, low birth weight, low gestation weight. Risk factors: other risk factors are asphyxia, shock, pathogenesis, normal development of retina. The vessel reaches the nasal periphery after 8 months of gestation, temporal periphery about 1 month after delivery by effect of VEGF. In premature birth, the production of VEGF is down-regulated and vessel migrator is halted. Oxygen-regulated vascular endothelial growth factors and non-oxygen-regulated insulin-like growth factors are produced in excess, resulting in neovascularization, fibrous proliferation, progressively resulting in different stages of retinopathy of premature described below. Clinical features: condition divided into active and cisarterial ROP. International classification ROP is based on stage and zone extent of ROP. Stage 1: demarcation line formation at the edge of vessels, define vascular and avascular retina. Stage 2: line structure of stage 1 acquires volume to form ridge. Stage 3: ridge with extrarenal fibrovascular proliferation into vitreous. Stage 4A: subtotal retinal detachment not involving macula. Subtotal retinal detachment. Stage 4B: involving macula occur in this stage. Stage 5: subtotal total retinal detachment. Zone of ROP retina is divided into 3 zones. Center of the retinal map of ROP is the optic disc, not the macula as in the retinal charts. Disease of retina. Zone 1: circle drawn on the posterior pole with the optic disc as center and twice the radius from center of disc to fovea as the radius constitute zone 1. Any ROP in this region usually very severe because of a large peripheral area of avascular retina. Zone 2: a circle is drawn on the optic disc as center and distance from center of disc to nasal ora serrata as radius. Area between zone 1 zone 2 1 and this boundary constitutes zone 2. Zone 3: temporal arc of retinal left beyond the radius of zone 2 is zone 3. Extent of involvement denoted by clock course of retinal involvement in particular zone. Stages of retinopathy of prematurity. Stage 1: demarcation line. Stage 2: demarcation ridge. Line develops into ridge with height and depth. Stage 3: extraretinal neovascularization and proliferation. Stage 4B: subtotal retinal detachment. Stage 5: total retinal detachment. 12.7 Division of retina into zone 1 to 3 and clock hour position to depict involvement retinopathy. Other features: plus disease to present the engorged vein, tortuous arteries in at least 2 quadrants. Pre-plus is labeled when venous dilation artery torture is more than normal but insufficient. Aggressive posterior ROP. Rush disease refers to ROP located in zone 1. Plus disease with plus disease out of proportion to peripheral retinopathy. ROP is posterior zone 2 with severe plus disease. Threshold disease refers to stage 3 plus ROP with plus disease zone 2 and zone 1. Pre-threshold disease. Early treatment of retinopathy prematurity group has classified pre-threshold into 2 types. Type 1: high risk pre-threshold disease which needs to laser photocoagulation. It includes zone 1, zone 2 plus disease stage 2 3. Type 2: zone 1 zone 2 non plus disease stage 1 and 2. non-plus disease. Stage 3 differential diagnosis. Active ROP needs to be differentiated from familial exudative veterinary retinopathy. Advanced retrolental fibrillation need to be differentiated from other cases of leukocoria. Management treatment of well-established disease unsatisfactory. Prophylaxis is thus important to reduce high-risk ROP. The premature newborns should not be placed in incubator with an O2 oxygen content more than 30%. Effort should be made to avoid infection attacks of apnea. Early diagnosis treatment necessary to prevent blindness. High-risk cases. Screening protocol. All premature material born less than or equal to 32 weeks of gestation age, those weighing 1500 gram or less, first section by indirect ophthalmoscopy should be done within 4 to 6 weeks. Then image retina labeled when vessels are short of 1 disc diameter or nasal. ROP when present should be classified at this stage. Subsequent follow-up examination. Treatment stage. Immature retina stage 1 to stage 3. Treatment protocol. Laser treatment, post laser surgical treatment, laser photo collection using diode laser, frequency doubled YAG. Delivery should be carried out in all patients high risk patient. Post laser treatment, antibiotic steroid eye drops should be prescribed for a week. Surgical treatment, patient with stage required sparing vitrectomy along with endolaser photo collection, retinal detachment.